Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
All right, welcome to the Pod of Inquiry. I'm really excited today to introduce my guest, Dr. James Anderson. Jim's been a personal friend of mine and colleague for 22, 23 years, and he's developed an extremely prominent and well-recognized clinic in the specialization of lower extremity peripheral nerve and chronic pain, both in Fort Collins, Colorado, and just north of Denver in the suburbs. Over his journey in peripheral nerve surgery over the last 2 decades, he's published some really what I consider important papers, and one of them is on restless leg syndrome. I did another episode on this subject with Dr. Kent DiNucci, who's another excellent peripheral nerve surgeon, by the way, who actually had nerve decompression surgery on himself for this condition back in Season 1, Episode 17. I know you'll find this conversation with Dr. Anderson extremely educational, and it probably will offer you some educational insights as a treating physician, or perhaps if you're a patient suffering from this incredibly common condition, it will help you get an accurate diagnosis and lead you to an area where it may actually be treated. You'll learn about diagnoses, common pitfalls of conservative treatments, and how nerve decompression surgery may alleviate the condition completely. So please enjoy this conversation I have with my good friend and colleague, Dr. James Anderson. All right, welcome to the Pod of Inquiry. I'm here with Dr. Jim Anderson from Fort Collins, Colorado. Jim, how you doing, man?
I'm doing really good. Nice to talk to you.
Yeah. We've it's been a while since we've had the ability to collaborate on crazy stuff, but look forward to some of the upcoming meetings where we'll cross paths again. Today, we're going to talk about some of the work that you did, and I have to, before we get started, I've got to commend you because you've really published actually several great articles in very high-level journals. And so, from a colleague in ANS with you, I want to take my hat off to you for that. Today, we want to talk about one of your papers called Nerve Decompression and Restless Leg Syndrome, a retrospective analysis. And you published this back in Frontiers in Neurology 2017, right?
Correct.
Yeah. So
Pretty wild.
It's very interesting how pervasive restless leg syndrome is. I did an episode a while back with one of our other colleagues, Dr. Kent DiNucci, where he actually suffered from the syndrome himself and has had nerve decompression, successful nerve decompression like you describe in your paper. But so tell me, when did the light bulb go off on this? As far as what was the clinical impetus for you to get going on this study?
That is a real good leading question. Good. Before I dive into that, I just want to thank you and commend you because you're really responsible for where I'm at. And it wasn't for you, I probably wouldn't be doing nerve. Maybe I would have, but I got into it really early on, thanks to you coming to me and suggesting that I go back and get trained on nerve decompression way back when, 20 years ago.
Yeah, probably more than that, maybe even.
Yeah, 22 years ago.
Exactly.
Because we might have 20 doctors you had recommended go back and have training back with Dr. Dillon. So really appreciate it. One, thank you.
No, it's been my pleasure to work with you all, and it's been a really good group, and hope to encourage I hope to encourage some of the, well, I said, I hope to encourage some of the listeners to really heed what you just said, because I've had to drag a few people kicking and screaming to the Association of Extremity Nerve Surgeons meetings, and none of them have regretted it. And in fact, some of them have said totally changed their lives from a practice standpoint. Yeah.
So it really, it keeps me passionate about the profession, really does. So, so that's a good leading question. When did the light bulb go on? My story goes back, it probably might have been 12 years ago, actually. In doing surgeries for neuropathy, it led me to start to see that we might be helping people with restless legs. So, and a lot of it came to me when I was doing surgery on patients suffering from neuropathy, whether it be diabetic or non-diabetic neuropathy, and I would have them, they would have decompression surgery. Maybe it was on the tarsal tunnel. And back then, we really didn't do the superficial perineal nerve that much. We do the common perineal nerve decompression, maybe do the deep perineal nerve decompression, and we do the tarsal tunnel decompression surgery. So, and some of these patients would say, oh, yeah, I'm pretty happy with the results. I'm maybe 70% better, but I've got these weird sensations, and they seem to be, to me, emanating from the area of the superficial perineal nerve. And I actually said, well, maybe let's take you back to surgery. And I did that on a few people, and they're like, oh my gosh, it's really changed my sensation, my results. It feels much better. But their symptoms that they're describing might have been more like a pulling or a tightness or just an odd sensation. And some of them didn't describe it maybe like a classic restless leg symptom, but nonetheless, I started doing this, and it got to the point where I always would do the common and superficial perineal nerves at the same time. And then, so it was a very gradient thing. I always tell my patients that it went from people that had probably 95% neuropathy symptoms with just a little bit of restless leg symptoms to gradually I got more courage to do surgeries on patients that had a higher percentage of restless leg symptoms and a lesser percentage of neuropathy symptoms, because they go hand in hand quite a bit. So that now I'm much more confident in those patients that have, kind of minimal neuropathy symptoms, but have a lot of the restless leg symptoms, which for the listeners, I might want to go over with them, just because that's how restless legs is diagnosed. It's an odd disease because it's primarily diagnosed by the patient's history. It's they can go to sleep centers and all that, but it's
before you jump into diagnosis, which is a really important thing, and when reading the paper, I think that we need to talk about how to diagnose this. But before you get into that, my experience with restless leg syndrome was patients that I had done triples, not even the superficial perineal, would come back, and I remember this very early on, and I didn't pay that much attention to it, but they would come in and they would say, I'm doing really good, but I noticed one thing, I'm sleeping better because I don't have the restless leg syndrome anymore. So it was almost like they were saying, and I just kind of like, okay, and at first it's like, well, that's great. I didn't really give it much thought. And then more and more people came in, and I think you probably saw the same thing. And then we also would see the same thing with low back pain. A lot of times patients that had common perineal nerve decompressions or common fibular nerve decompressions, they would come back and they would say, you know what? I don't know if this is supposed to happen, but my low back feels a little bit better. And, I would explain to them from the standpoint of, double crush scenario and that type of thing, that, we didn't really do anything on your back, but maybe helping you distally help that proximal entrapment as well. But it was really the patients that kind of educated me on this restless leg thing as like it was like kind of a byproduct that I hadn't even been thinking about. Is that kind of what you saw?
Exactly.
Okay.
Exactly. And then I that's a very good point, because it was feedback from the patients, and I love the way you described that, but that's exactly what it was, is feedback from your patients, and maybe try to help them more. And then, I think it's more the areas that you're doing surgery on have an effect on it in a peripheral manner, but I think there are certain tunnels that have more likelihood of being implicated for restless legs than others. Like
Right.
maybe tarsal tunnel, maybe not as much as soleal sling, for instance.
Right. And then, of course, I think you would have to put common fibular and superficial fibular way up at the top as far as, yeah.
Exactly.
So, yeah. Well, it's kind of interesting how we learn so much from clinical experience.
Right.
And it just makes you want to keep your eyes open even more and really listen to what the patients are telling you, because they've got some really good stuff in their history of present illness and their history after, you do some type of decompression surgery. So, all right. So I interrupted you a little bit there to talk about the diagnosis, but in your paper, you eloquently point out that there's primary and secondary restless leg syndrome. Do you want to break that down for people?
But just a little bit, yeah.
Yeah.
Primary, there's more of a genetic factor involved. Possibly it happens when you're younger. Kind of an age to think about. The primary would be under 45 usually.
Okay.
Under 45 years of age is primary, and a lot of times somebody else in the family has had it. They have no secondary problems like diabetes, etc. And there's a strong chance of it being in the family, maybe. And in a lot of cases, you're going to read in papers that there may be a 50% chance that if somebody has restless legs, somebody else close in the family, the mom or the sister, brother have restless legs also.
Right.
Then we get to be more middle age and older. Maybe Parkinson's, maybe diabetes kicks in, and it can be secondary to other issues.
So
later.
So in a way, it's kind of like complex regional pain syndrome 1 versus complex regional pain syndrome 2.
Right.
Where in 2 we've identified a focal or multiple focal entrapments, whereas in secondary, even though I think in your paper you noted that even in the primary cases there was still a component, and I forget what percentage it was, of folks that really had demonstrable nerve entrapment.
Right. I can't quote you that right now, but no, it's very similar. That's a good analogy.
Yeah, and so when I was reading the paper, to me it seemed like there really might not be that much difference between primary and secondary as far as maybe just the nomenclature, because you still have these components of nerve entrapment in both.
Right.
And
exactly.
So don't just because somebody has a more likelihood of a genetic component doesn't mean that they don't also have a nerve entrapment, and with good evaluation, then you may pick that up, which is a big thing, because then you can actually do something for the patient other than just giving them a drug.
Exactly.
Yeah.
I totally agree with that. That's,
yeah.
I factor in, you're just looking to see if there's compression sites.
Right. And so have you done anything? I didn't see anything in the paper about peripheral nerve blocks as far as helping you with your diagnosis or anything like that. I mean, you told me earlier that the diagnosis is really made most often by subjective descriptions and complaint.
Exactly. But no, I do diagnostic injections from time to time. It's not something I have a set rule and it's in my algorithm to do them on every patient. But yeah, I do it on many patients. So.
It's interesting. It's very interesting. It would be great to, we've got some pretty good diagnostic block techniques, and I've been harping for years now on the Phoenix sign, and
right.
I didn't really want
to. That's a great tool, by the way.
Yeah. So. Well, it's fantastic because it allows you to diagnose a lot of these people that have, they've been just relegated to, it's just, your disease process, that type of thing. And it would be interesting to see from a diagnostic standpoint, maybe I can talk to you about this, because one of the things that we have seen with the Phoenix sign is that it's very predictive of a positive outcome. So if somebody gets more motor strength after the small little block, it would be interesting to see how they do from a restless leg syndrome as well. Could there be some predictive benefit, in the diagnosis? That's something I want to, after we get off, let's talk about that, because I think we need to maybe do another little clinical research study on that. So let's get into the diagnosis just a little bit more. If they're under 45, by definition or convention, it's more thrown in that primary versus secondary category. What else? What are some of the descriptors that are, helpful to you?
From their, do you want me to go through the symptoms pretty much? Or?
Yeah. So let's say a patient comes in and they say,
right,
I have XYZ.
Right.
How do you ferret out that, they have restless leg syndrome, and we can then go into the diagnostic from a clinical standpoint, but more from a subjective standpoint.
Subjective.
Yeah.
Well, I mean, a lot of this is pretty obvious, but I'll go over it anyway for our listeners. They're going to have symptoms of creepy crawly, maybe cramping. A lot of times it's going to be up in the thigh, or up in the calf, I should say. Kind of creepy. Again, I say creepy crawly. Jerking, twitching is quite common. But probably the biggest thing of all is just nervousness or anxiousness. They want to get up and move. They can't. They don't want to lay down. And when they sit still, they just feel like they got to get up and move, and that alleviates a lot of their symptoms. And it does happen primarily at night when they go to bed. But as it gets worse, it can happen during the day when they're just sitting and they have to get up and move. And the symptoms tend to be distal to the knee. That's really important. Some can extend, and sometimes it's extending down into the foot quite a bit, but that's more unusual. It's more patients, it's going to be between knee and ankle where their symptoms lie. And also for the decompression to work, if people have a lot of symptoms proximal to the knee, I don't consider them a good candidate.
Okay.
If they should have at least 50% or more distal to knee.
Okay.
I just haven't seen that it helps if it's more proximal, and it's a rare presentation for it to be proximal to the knee. Maybe, but the percentage is higher below the knee.
Now, have you ever had the spouse help out in the diagnosis because I can remember patients now in the clinic and they'll say, Harry doesn't know this, but man, he jerks his legs around all night. I can't sleep. I have to get up and go in the other room because he's thrashing around. And the poor guy's going, oh, I didn't know that. Kind of like snoring,
Oh, I know. All the time. Some people sleep right through it, and other people are relegated to the couch, and that's what's tragic about it. It's just the suffering these people go through. And the problem is at night, because you and I, most people go to bed, we sleep, but they don't do that. And they suffer lonely. I mean, it's a lonely disease because they're suffering when everybody else is sleeping and getting rest. And the other thing I'll say just emotionally about them, and maybe this doesn't help the doctors in diagnosing it, but they are so anxious because they just don't know what the next night's going to be like. The day during the daytime, mentally they become depressed or anxious because what's tonight going to be like, and what's tomorrow going to be like because of the lack of sleep.
Yeah, not only that, but the lack of sleep or the sleep deprivation increases anxiety, depression. You've got the whole subset of symptoms just from sleep disturbance. And I think I saw somewhere, I don't know if it was your article or something else that I was reading, is that a lot of diagnoses will come from the sleep centers.
Right. That could be. Right.
Because they, like we said, some of them don't even know they have it. They're just thrashing around and not getting good sleep. Yeah. One quick question I wanted to ask you, because I really haven't made this connection myself, but are the restless leg syndrome patients, if they've had more activity during that day, more biomechanical demand in their lower extremities, does it seem that they have maybe worse symptoms that night? Is there any correlation that you've seen between activity?
That's a good question. I think it might make it worse more times than not. Right. But I also have people that purposely try to be really active so they can sleep.
Right.
Almost like exhaustion. I had one gentleman, I can't remember if he ran or walked for 2 hours a day or more.
Yeah.
Just so he was exhausted before he went to bed.
Yeah. Yeah.
So, but I don't have a clear answer.
Okay.
Sure. All right. But I think if anything, it tilts towards, creating more lack of sleep, more symptoms.
All right. So the diagnosis is primarily made then by you listening to the patient telling you their symptoms, and then you make a decision whether or not to go ahead and
correct.
Now,
and there's quite a few people out there maybe 10% of the population at most have restless legs, and it's been said maybe just 5% or less, it's very severe.
Mm-hmm.
And so I consider that too, because some people actually have very mild symptoms. Women, maybe you may know this, but pregnancy is related to it a lot, and it gets worse after pregnancy. Sometimes it just goes away, but real common during pregnancy, or it might continue after.
What do you think the male to female ratio of restless leg syndrome is? More females or males?
I think it's twice as many female as male.
That's really interesting, because if you look at a lot of the neurological disorders, there's always a preponderance that the female to male ratio is higher for females than males. That's kind of interesting. Yeah. All right. So what about conservative treatment for restless leg syndrome? What's been your experience? I know a lot of people put people on Lyrica or gabapentin.
Yeah. I mean, I don't use pharmacological treatments myself.
Okay.
But I mean, what's out there is, it used to be the dopamine agonists.
Yeah.
And it still is. Mirapex, ropinirole.
Right.
But there's and basically that helps increase dopamine levels in the brain. And that's kind of the mainstream way of dealing with this. There are studies that show that there may be less iron in the brain. Mm-hmm. And then iron's necessary, for the neurotransmitter dopamine.
Right.
And so the go-to would be iron, maybe IV iron treatments would be an option. And then there would be the option of, again, ropinirole or Mirapex, and they help increase dopamine levels in the brains. But I think 40% of patients go through augmentation, which, simply means that it just becomes less therapeutically helpful, and they have to take more and more, and it actually then might extend into their arms and such. So it becomes the RLS becomes worse and might be more expansive into the upper extremity with augmentation. And then it's a real bear to get them off those dopamine agonist medications at that time. And I think more and more, doctors that are treating with medication are going more towards Lyrica and gabapentin to start with, and using those drugs. And
but the problem
as a last result.
Right. But the problem with a lot of people don't like to take gabapentin or Lyrica because of the side effects that are, commonly associated with that. So you have the patient in the office, you discuss everything with them. How many of them are already on ropinirole or gabapentin or Lyrica before they even get to you?
High percent.
Okay.
High percent. I mean, I'd say 80% are trying some pharmacological agent, and there are a few that are really stubborn. They just refuse to take them, and then they find out about what I do, and they're just suffering, and they come in and just go the route that I'm suggesting.
And now a message from our sponsor. Well, folks, if you're over 40 and you're not using a supplement to augment nitric oxide production, you should really rethink that. This molecule is absolutely imperative to health, not to mention the cardioprotection. Nitric oxide is a physiological molecule that does so many things for your health. I never miss a day of nitric oxide supplementation. That's how important it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, just go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration, and I am certain you will be pleased not only for yourself, but for all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see that nearly every one of them will be deficient. When they see this result, they will want you to start them on it immediately. Now, thanks to approved medical solutions, you can give them the best care without the worry of oxalates. Thanks for watching. You can start today. Now, what's the percentage that then after the decompression don't need any pharmacological?
I tell my patients, I think about 70%.
Okay, that's pretty good.
I have no data I mean, that's just gut, honestly.
Right.
But I'd say 70%. And that's why I tell my patients, and 30% don't get off medication, but they can lower the dose and they don't have to keep increasing it. And they're pretty happy with that.
Yeah, because that's a big deal. We know as we titrate up GABA and Lyrica,
right,
the side effects go up. So yeah, if you can bring them down, that's a win, a victory.
Oh, exactly.
Yeah,
it's a big
for
win.
sure.
And it's really one of the challenges is how to titrate them off the medication.
Right. Right.
It's very slow sometimes, but
yeah. So how many of them are bilateral versus unilateral?
Oh, high percentage are bilateral.
Right.
I'd say at least 80, 90% probably bilateral.
Okay. And what about the unilateral? It's a smaller percentage, but is it more associated with repeated ankle sprains or previous trauma, whether that be just biomechanical aberration?
It is so infrequent. I would say none of the above. I'm not sure.
Okay.
I think I can remember back, there are some that have been, maybe there was some kind of trauma, there was a surgery involved.
Right.
Maybe a knee replacement, maybe an ankle surgery.
Right.
Those types of things would make it unilateral.
Yeah.
Possibly.
Well, the reason I asked you that question is
Sure.
I just had a patient a couple of weeks ago that had a total knee arthroplasty, and his description was, I've had pain ever since the surgery, and I also got restless leg syndrome. And my question was just in that leg or both legs. And the patient, as I recall, seemed to think that it was just more of a unilateral restless leg.
Right.
And so it would make sense that if you had some kind of trauma, that's going to set up, more likelihood of that.
It's amazing to me, just to interrupt for a second, how many people, when they have, hip or knee surgeries, it really, how it affects the, neuropathy, restless legs and lower extremity for sure.
Yeah, no, I think, I think you could open up a center that would be extremely busy, and you just would say, do you have chronic pain post-hip or knee arthroplasty?
Exactly.
And the answer would be, yes, and the waiting rooms would be filled with it. It's pretty amazing. And
common.
And then nobody pays attention to them.
It's frustrating because they don't know. The patients have to seek us out.
Right. And usually the surgeons don't know that, their procedure, even though they do it perfectly correct, and there's no negligence or substandard, it's just that nerve has a high preponderance for acting up, so to speak, after those types of procedures and everything. So how many of them are, I'm assuming you're staging your surgery from first leg, second leg. You're not doing it okay. Did you see in your clinical experience where after you did their first leg, even though they had bilateral presentation, they said their symptoms were decreased somewhat on the contralateral side? You recall seeing that?
Yes, I have.
Okay. Because that would compare or correlate. That would correlate well with what Shai Rosen published in his study about the non-operative leg showing an improvement.
Right.
And there's a lot of good neurophysiology that explains that. I think Sonny Yamasaki, who you've worked with on your studies, and he can explain it well between the way the thalamic tract in 20% of the time it doesn't cross over like it's portrayed to do. So you can, and then the neuropeptides floating across the spinal cord and that type of thing. But I just wondered if you had seen that as well.
Isn't that called the phrenic? Is that what phrenic phenomena? I
I
thought there
don't
was a
know.
name attached to it. That
Yeah, I'll have to look
it's
that up.
actually a real thing.
Yeah, no, it's real.
Published it.
It's real. So let's talk about some of the results, because I think your results were very good in this. And if you look at the VAS changes, your scatter plot, I mean, it looks like you're bringing these people down pretty significantly.
Right. Yeah, I mean, we had 42 patients, and so this is just a retrospective population, study back. I think it's 2015 to 2017, and everything was significantly, statistically significant, except for the symptoms of pulling, and I believe the other one was weakness.
So what were you measuring on weakness? That was a subjective evaluation on the patient, or was that your motor?
That was objective.
Motor
that
testing?
was not. That's subjective.
Okay.
VAS score.
Okay.
So VAS scores.
Yeah. So a lot of them you're going to see if they have a common fibular component entrapment, they're going to have some weakness in their EHL.
Correct.
And if you look at that,
I might add real quick in the clinical exam, just a little something. These people don't even realize when you do your exam, just from muscle testing, they have weakness from, maybe soleal thing entrapment. Maybe they can't do toe spread. That's a clinical thing.
Right.
It just amazes me that they're floating around in the medical universe and they've never been checked, or that's never even been evaluated, but they actually have motor weakness and restless leg. So that really helps confirm nerve damage.
Yeah, it's very, it's a very telling sign when you ask them to hold their big toe up and you press down on it, and they have perfect strength on the other side, or very weak, on the affected side. But I was going to ask you about the differences in what you think the neuroetiogenesis, if that's even a word. It sounds pretty fancy though, doesn't it? Neuroetiogenesis. We make that a word. All right. So anyhow, how much of it, that's a nice, it's fun to BS about this stuff, but how much of it do you think is primarily fibular component versus the tibial component?
Tibial.
You think it's more tibial?
Quite a bit tibial. It's both. But in my study,
yeah,
I mean, I'm going to, if you don't mind, let me indulge you in that a little bit.
Yeah, please do.
Okay, so in the beginning, I was noticing it with common and superficial decompressions.
Right.
And then, you're one of the early ones to do soleal sling decompressions. And then I started to notice it with soleal sling. So now, high percentage, maybe close to 90% of my cases, I do soleal slings on.
So you're doing soleal and the fibular component?
Yep.
See, that's really interesting because...
And there are some that I still do just common and superficial, but they're more in the minority. And there's just a few, but their symptoms are all calf, like tremendous cramping in the calf and very localized to the calf that I've just done the soleal. That's pretty rare, but I've done that too. Yeah. And I have a one outlier guy that I did the common, superficial, and soleal on, and he had really bad restlessness on the top of his foot, and I ended up doing his deep perineal nerves later on, which was interesting.
Well, I think you can get restless leg syndrome from anything that hurts during the night. So if they've got, some kind of a contusion on the dorsal aspect of their foot and that nerve is entrapped, they go to bed and, they can't get in a comfortable position. And so it wiggles and moves around. Now it's real interesting because if you look at the anatomy of the tibial nerve versus the common fibular nerve, the tibial nerve is much more robust than the fibular component. It has more vascularity, more arterial contribution than the common. And so you don't see, like in the literature, the common fibular is the most common nerve entrapment in the lower extremity, and I think it might be the second or third most common entrapment in the human body, followed by ulnar and median nerve compression in the upper extremity.
Okay.
But it's clearly in the literature for other things that the soleal sling is more secondary. And now what you're telling me in restless leg syndrome, in your experience, it seems to be more primary.
Well, I don't want to exclude. I think it's there for most people. I really do.
Okay.
And I want to go down another pathway with you here because I think there's a vascular component to this. There could be.
Okay. Let's talk about it.
And what's that?
All right, let's talk about it.
Yeah. So here's the hypothesis. And if I do more studying, it's probably going to be on this, if I create another study. And by the way, we have a second study that we're getting published now. Hopefully it's going to be accepted pretty soon. But I did intraoperative nerve monitoring.
Okay.
It's going to have more objective findings that this works. And it has more rigor than the published paper that you're looking at right now. But no, the other idea would be that all the nerves we're talking about are in leg compartments. And so obviously, arterial blood flow is, high pressure system. The arteries are stiffer. The blood has to make a U-turn when it gets down the foot, go back up to the heart. And so in these leg compartments, like the posterior leg compartment, I think that as the vein is traveling, bringing blood back up to the heart, it's getting constricted also.
Right.
In the soleal area and maybe on the anterior part along the superficial perineal nerve. In other words, blood's attempting to get back to the heart. And when the patients are laying down or just, sitting, because there's no contraction of muscle, it's not getting blood out of the leg compartment and getting back up to the heart. And I think it's almost like a very mild compartment syndrome that could be going on.
Right.
So I think there's a venous component to this that I don't think we fully understand yet. And it explains to me why people get so much relief when they get up and move, because now,
they're getting that reflux disseminated into other areas, and so you believe there might be less compression from a vascular component.
Exactly. So like the soleus is a great venous pump.
Right.
And it gets you're moving or standing and it gets the blood pumped back up to the heart. And until you do that, you're building up pressure in these leg compartments. So I think, and that irritates the nerve. I just think that's an idea that should be pursued. And we're hopefully going to do a study in the near future on that. So.
Well, you could make maybe the same argument in, other non-restless leg syndrome patients where they will say, like diabetic peripheral neuropathy is a perfect example. I don't have any symptoms, the patient will say, when I'm up walking and I'm about, but boy, when I go to bed at night, it just drives me crazy. Maybe that's something going on.
Point. Yeah. Yeah. I think it's a curious question,
Right. So you mentioned intraoperative nerve monitoring or nerve testing. Explain a little bit for the audience. The physicians know what it is already, but explain that a little bit so that the non-physicians can understand how objective this is and how quickly you see these changes intraoperatively.
Yeah, all that is we put needle electrodes in muscles of the leg, and then before that nerve tunnel is opened or decompressed to get rid of pressure, we stimulate the nerve and we do it at a set power setting, and that power setting remains the same throughout this exam. And so we stimulate the nerve, and then the decompression surgery takes place. And usually within minutes of the decompression being completed, we re-stimulate at the same power level, and basically you're measuring the amplitude of the impulses going to the muscles that the needles are in. So it's like, if you've been for those that aren't in medical and you're listening to this, if you are and you're a layperson, it's like the action potentials you might have learned about in biology in college. It's so much. It's just how much are those muscles wanting to contract. So we've seen as much as 300% change within minutes on the operating table before the decompression versus afterwards. And we have two studies out on diabetics that had decompression, and hopefully we're going to have one on patients with restless legs.
No, that was another study that I thought you did. It was fantastic. And that was, I think, I haven't looked at that for a long period of time, but wasn't that the British Journal of Neurological Surgery or something like that you published that in?
Yeah, that was in Europe.
Yeah.
Yeah, it was.
Yeah.
Shoot, I can't remember right now.
Yeah.
It
Yeah.
should be right here, but I can't.
But as I recall, it was a pretty prestigious journal.
Yeah, that was a good journal.
Yeah. Yeah. Now, there's some really important points about intraoperative nerve monitoring that I want to expand upon a little bit, because a lot of neurologists will say that nerve decompression surgery doesn't work in patients with diabetic peripheral neuropathy, but yet they'll still say that they'll send carpal tunnel patients over that have diabetic peripheral neuropathy and decompress it. But somehow in their wonderful neuronal flickering, they can't make the jump to the abyss that the nerve might actually be pinched in the lower extremity as well as the upper extremity. So when they say it doesn't work, and you can say, well, that's absolute bullshit, because I have objective intraoperative nerve monitoring that shows immediately after this nerve's decompressed, it functions that much better. There's no way that's a placebo effect. There's no way that the patient can game that because they're asleep.
Right.
You know?
Exactly.
Yeah. So I
agree. I concur.
Yeah. No, I think it's important.
We've tried to give that diabetic, talk. We've tried to present that a couple times.
Yeah.
At the American Diabetic Association. We've never been able to lecture there. So
isn't that interesting? I think they're still so in love with their food pyramid that is still wrong.
Exactly.
That they I mean, it's so frustrating fighting these.
Well, I think that's what motivates. That's why you and I are doing what we're doing. We're both still very passionate, motivated, and we want patients to know the truth, right, Steve?
That's right.
What
Well,
we do.
And the patients will speak volumes, because they will go back and they will tell their other providers that they said, this surgery doesn't work, and they'll go back and tell them, wait, I'm here just to tell you that I don't have that pain anymore. I can sleep now because I don't have restless leg or whatever it is,
Right.
And they will speak very loudly on your behalf.
And they will.
Yeah.
And one thing I always look at things, the yin and yang of life, I guess. So, and I've even shared this with patients from time to time. Even if I fail you, at least you knew, you're looking at a different option. You know what I'm saying?
Right.
And in their mind, they have more peace because at least they understand this makes sense. I have a compressed nerve.
Right.
And just like somebody knows about carpal tunnel and it doesn't work, well, at least they knew that. But right now, I think they're being kind of moved from doctor to doctor to doctor, and it seems kind of hopeless. And a lot of the things we do, I think, really make sense to them when they start to understand it.
Right. Yeah. So tell the folks a little bit about the surgery itself, how it is from a perioperative standpoint, when you let them get back to regular activity, just so that they have a little bit of an idea of what you do.
I usually do one leg at a time. Whether people are coming from out of state or local, if they're local, I might wait 2 weeks between legs. Out of state, I usually I feel best to do one leg and make sure that they can sense something on the first leg before we do the other one, and that's done a week later. And then, but they're walking. I usually just tell them to slow down for about 3 days, maybe 45 minutes per hour of elevation.
Right.
But I want them to get up and walk around a little bit. But then after about 3 days, they're doing their basic stuff they got to do to get around. And when you get into work, that's a whole nother dilemma of how long they need to be away from work. But if somebody wants to go on a long hike, it's probably going to be like maybe 4 weeks, and that's mainly to make sure the incisions are well healed.
Right.
Type of thing. I think it's very difficult for patients to kind of damage or do anything wrong that would make the outcome less by doing too much. I think the biggest problem I see is people that are overactive. Maybe they're going to have a dehiscence, or they're going to have problems with the incision healing.
Yeah, no, that makes sense. And, there's that delicate balance between, getting them going and having mobilization so those nerves slide and glide versus, putting them into a some type of immobilization, which is usually a disaster. And
exactly.
that type of thing.
We make them move. All we put on is little off-site dressings and Coban. That's our dressing.
Yeah.
You have to keep it dry for about maybe 3 weeks at most. And most people are really surprised how little pain there is. They're really impressed. Sometimes all they're taking is ibuprofen.
Yeah, that's really interesting. And to be fair, it's much more involved and involves more tissue to have a tibial nerve decompression than a common fibular decompression. But yet the folks usually say, I didn't have much problem with it. And you're going, wow, okay, that's good. Yeah. That's a good thing. Nice. But yeah. Well, cool. Anything else you want to add on restless leg syndrome before we wrap it up?
Yeah, well, I just wanted to mention the direction we're going. I mean, I think I like what you said about neuropathy and blood flow, because I think it's something that we can get kind of focused and tunnel visioned on just the nerve, but hey, maybe there's something going on the arterial or venous side. And I might plug my book if somebody's out there. I wrote a book called The Perfect Night's Sleep.
How come I don't have a copy of that, Jim?
I don't know. I can autograph them for you.
Would you sign one and send it to me?
Maybe so.
I'd love that.
Actually, Dr. Dillon and Dr. Marie Samino endorsed it. So
very cool.
People can get that on Amazon. It's called A Perfect Night's Sleep. So it's nice because it's kind of giving my history.
Yeah.
You're mentioned in here, my friend.
Well, I'm so hurt right now, Jim, that I don't have a copy of that book, man. I would have written a glowing paragraph for you, because I admire the work that you've done. It's really important, and
appreciate it.
We need more of that. And a lot of people are not suffering and having much better lives now because of what you're doing for them.
Well, if there's a 2.0 version, I'll let you
write it. Yeah. All right. So before we end,
I think I'm done. I think that's
all right. Well, before we jump off, tell people where they can find you.
Okay.
And it's not the Pale Ale Club in Fort Collins.
No. The main practice is in Fort Collins, Colorado, but we also have a Broomfield is North Denver, so we're actually Denver and Fort Collins.
Well, the reason I said that is because when I came up to visit you there, I don't know, this must have been 15 years ago, I couldn't believe how many brew pubs there were. It was like every 2 corners there was another, specialty brewer.
Yeah, no, that's a real big.
Yeah.
If people have heard of Fat Tire, that originated here, and it's a lot of breweries here.
Yeah. All right. So if you have restless legs and you want to see Dr. Jim Anderson, look him up. He's in Fort Collins and Broomfield.
Right.
Okay. Colorado. And Jim, I came across your paper on vagal nerve stimulation. I want to bring you back for another episode just to talk about that, because I love what you're doing from that standpoint. So can you come back and do another episode with me for that paper? All right.
I'd enjoy that.
All right, man. Thanks so much. I appreciate you. And hopefully I'll see you at the nerve meeting.
That's right. We'll see you.
All right.
Take care.
This episode is sponsored by Savant Cellars, providers of boutique Tier 1 Reds at a Tier 2 price point. Let's imagine you are spelunking in a cave out in Napa Valley, and you come across some of the juice from Savant Cellars. You may just never want to come out until it's gone. Savant Cellars sources all of their fruit from the really big-name boutique vineyards. That's right, where the elites get their fruit. If we put a vineyard designation on our bottles, we would be contractually forced to sell our wines at 3 to 4 times our current pricing. Yes, full disclosure, I am one of the 3 principals, and I'm very proud of our wines. Savant Cellars is the genius of wine. Simply great wines, vintage after vintage, crafted in a Bordeaux style so you can lay them down for years or drink them now. They simply just get better. Use the code SPELUNK15 to get a 15% discount at savantcellars.com. That is CEVANT Cellars.com. Spelunk15.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, podofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show, if used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.